Okay, thank you very much. I'd like to welcome everyone to the Department of Medicine Grand Round. For those who don't know me, David Roth, and I'm a member of the Katz Family Division of Nephrology and Hypertension. I'm really pleased to introduce today's Grand Round, which is an invited lectureship to honor the memory of two nephrologists, both Doctors John Cuneo and John Richardson. I've been at the university long enough to say that I was fortunate to have known both men personally. Dr. Richardson and Cuneo received their medical training and some of their nephrology training at and Jackson Memorial. And in fact, Dr. Cuneo was a graduate of the second class of the School of Medicine. Both of these men were really pioneers in the early days of nephrology when dialysis was not that widely available and was a fairly new technology with limited access. They were both very passionate about nephrology and also about the importance of continuing education. In fact, I remember very clearly when I was an intern, resident, and junior faculty seeing Dr. Richardson at medical grand rounds every week when they were held at the VA hospital. Both men spent the majority of their careers working closely with Dr. William Anderson, who was their partner in practice here in South Florida for many years. And both of them were recognized as leaders in the medical community of South Florida. They were loved and respected by their patients and worked tirelessly on behalf of patients with kidney disease. Under the direction of the National Kidney Foundation of Florida and the leadership really of Doctors Anderson and Carlos Ramonde, Carlos was a longtime chief of nephrology at the VA. Both these lectureships were established by contributions that were made from family, friends, and a lot of medical peers of both men. Today's speaker joins a list of distinguished leaders in nephrology who have delivered this lectureship for more than 20 years. And really looking forward and honored with the speaker who we have today. It will be excellent. I will turn this over to the chief resident, as Dr. Weiss said, who will actually introduce today's speaker for Grand Rounds.
Okay, thank you. Welcome, guys, to Grand Rounds. Today's speaker, Dr. Ojo, is the Executive Dean of the University of Kansas School of Medicine with oversight of the Kansas City, Salina, and Wichita medical school campuses. Before coming to the KU School of Medicine in August 2019, Dr. Ojo served as Associate Vice President for Clinical Research and Global Health Initiatives and Professor of Medicine and Health Promotion Sciences for the University of Arizona in Tucson. His primary research interests are in the clinical epidemiology and clinical and translational research in chronic kidney disease and kidney transplantation, minority health and health disparities, and global health. Dr. Ojo earned his medical degree from the College of Medicine of the University of Lagos in Lagos, Nigeria. He then earned a doctorate in epidemiology and an MBA from the University of Michigan in Ann Arbor, where he rose to the rank of full professor in the Department of Medicine. He also was inaugurated as the Florence E. Bingham Research Professor in Nephrology, becoming the first African-American to be granted a named endowed professorship at the University of Michigan Medical School. Welcome to Dr. Ojo, and we can get started.
Thank you very much, Dr. Kobit. Good afternoon, everyone. I am delighted and truly honored to be the speaker today for the Cuneo Richardson Endowed Medical Grand Round. I truly believe that the pioneering work that these two physicians did in South Florida has been described by Dr. Roth, and prior to that, Ms. Sandra Pollack and Dr. Bill Anderson, is a testament to their passion for care for patients with chronic kidney disease. And my discussions today, I hope, will be a contribution in the direction of trying to reduce the scourge of kidney disease. Before I start talking about the subject of my presentation, I just want to note that I have been at the Miller School of Medicine several times, and I have some long-standing connection with many of the senior leaders at your institution. Dr. David Roth himself, his work on hepatitis C infection and kidney transplantation was inspirational and motivated a lot of the clinical outcomes work that we did in kidney transplantation at the University of Michigan for a period of 2 decades. In addition, I have worked with Dr. Gabe Contreras on the African American study of kidney disease and hypertension, during which a seminal publication by Dr. Contreras was on recruitment of African Americans into clinical trial, was seminal, and it's as relevant then as it is today as we talk about recruitment of African Americans into clinical trials of COVID-19 vaccine. Finally, I had the privilege of working with Dr. Warren Coopin when he was at the Henry Ford. In fact, Dr. Coopin was one of the mentors on my KO8 in the early 90s. So I want to say thank you to all the leaders at the University of Miami who have helped me along the way and contributed in some ways to some of the work that I will share with you today, because they helped to lay the foundation. I want to discuss apolipoprotein L1 associated kidney disease, and I want to do so in the context of global health research, specifically in the continent of Sub-Saharan Africa. The objective that I will hope to accomplish at the end of this discussion is to emphasize the role of apolipoprotein L1-2 risk allele as a major risk factor for chronic kidney disease in people of African ancestry. And those are individuals who are considered Black race living in the United States, in Africa, or elsewhere in the world. They are of recent African ancestry because what we understand about humankind is that all humans have some African ancestry, but those who have Black race currently are the most recent from that descendant line. I will hope to be able to identify the success factors and major funding sources for global health research, because I believe a leading academic medical center like the Miller School of Medicine should continue to be a leader in global health research, not only for the benefits of Americans, but for the benefit of mankind. Finally, I will shed some light on the epidemiology of apolipoprotein L1 renal risk variants and the implication of that epidemiology for kidney disease, chronic kidney disease, both here in the United States and beyond. Most of you know that end-stage kidney failure, which is the area that both Dr. Cuneo and Dr. Richardson worked on, is a very common disease. About 125,000 people in this country start dialysis or may start with a kidney transplant in the United States, and that we currently have about 750,000 people on dialysis, or with a kidney transplant, with nearly 250 people dying every day on dialysis. End-stage renal disease is not an equal opportunity disease. African Americans are 4 times more likely compared to non-Hispanic whites to develop end-stage renal disease. And in adults, type 2 diabetes and hypertension are the leading reported causes of end-stage renal disease, whereas in children and adolescent less than 18 years old, polycystic kidney disease and glomerulonephritis seems to be the main driver of this condition. The graph that I show here was based on a post hoc analysis of a randomized clinical trials, one of the largest clinical trials that was performed in the 1980s and early 90s called the Multiple Risk Factor Intervention Trial. And what I show here is systolic blood pressure regressed against the incidence of end-stage renal disease per 100,000 person year, or per 100,000 population per year. And what it shows that if you look at the blue bars, which represents African Americans, and the yellow bar representing non-Hispanic whites, that as blood pressure increases, the incidence of end-stage renal disease also increases. But the increase or the rate of end-stage renal disease at any level of blood pressure in African Americans is 3 to 4 times higher at any one blood pressure level compared to non-Hispanic whites. An important fact also is that apart from individuals who are hypertensive, that is those individuals who are in the last 2 sets of bars, who may have end-stage renal disease due to hypertension. Even in those individuals who are normotensive or have normal blood pressure, African Americans still had a 3 to 4-fold greater risk of end-stage renal disease, indicating clearly that the excess burden of end-stage renal disease in African Americans cannot be due to hypertension alone, because among those who are normotensive, the excess burden persists. So there has to be other reasons why African Americans bear this significantly greater burden. I'm going to look at investigational effort on end-stage renal or chronic kidney disease in people of recent African ancestry in the context of global health. But global health means different things to different people. So I borrowed a definition from the Consortium of Universities for Global Health, which says that global health is an area of research and study or practice that places priority on improving health and achieving health equity. Going further, it emphasizes transnational health issues and focuses on social determinants of health, approaches to solution. Importantly, I want to emphasize, and the bold words are mine, or the emphasis is mine, global health is a synthesis of population-based approach, as well as individual level care and precision health. I'm going to warn you ahead of time that the next slide, please do not try to read it. The purpose of showing this slide is not to induce seizure activity in anyone, but to just let you take a glance at the complexity of this particular slide. And what it reflects is the involvement of the Department of Defense in global health and global health research across the entire world. Dozens of agencies and billions of dollars is committed by the Department of Defense to global health and global health research. Within our federal government, we spend more than $10 billion a year on global health. What I show here is just a slice of the funding for global health that comes from different segments of the federal government. I want to point out the NIH has about 8% of its budget currently spent on global health. That is about $900 million to $1 billion. If one were looking for funding in global health, typically we will be looking at foundations and federal sources. We will be looking at the NIH Fogarty International Center, where the budget for global health is only $70 to $80 million. I'm showing this slide to point out an important component for source of global health research funding, and that is a funding mechanism called the foreign components of domestic awards. That is almost $1 billion. And that funding mechanism is an approach in which when you write an R01, a program project, or any other research grant, you could have a foreign component to it, provided you can justify the reason to do that type of research abroad. I point this out because many people who are interested in global health research are often looking in the wrong places. The traditional NIH institutes have significant global health funding. In the United States, in 2004, the government also established, the Congress established the Global Disease Detection Program, which is a global health research initiative to help the United States and the world address emerging disease conditions. 10 global health disease detection centers have been established across the world. They provide technical assistance for outbreak investigation. They prepare different countries for potential infectious disease that emerges, and the CDC plays the role of an expert to control and help to terminate outbreak. They also provide scientific support and public health guidance to different countries and help to build capacity. I point this out because the Global Health Disease Detection Program, apart from being a source of funding for global health research for academic medical institutions, it is also an avenue by which the United States supports global health in different parts of the world. And I want to point out here on this slide that China is one of those places where the United States has a substantial presence in global disease detection. Unfortunately, our CDC experts were removed from China in 2018, including being removed from the Wuhan Institute of Virology. We might have ended up with a different outcome if that was not the case. What I show here is the number of clinical trial sites and participants in clinical trials for clinical trials that are used for registrations of drugs and biologic at the FDA. And the message that I want to convey to you is that for most of the drugs that are approved by the FDA today, nearly 60% of the clinical trial participants are outside the United States. For biologic, the number is close to 90%. And in fact, the COVID-19 BNT162b2, the Pfizer vaccine that is going to be approved shortly, 75% of the clinical trial sites were in other places outside the United States. I think everyone at an academic medical center who has an interest in global health or global health research should be familiar with these funding sources if you are not already familiar with them. The 5 funding sources that I've listed here represents $20 billion of federal government commitment to global health and global health research. So let me come back to kidney disease. So we have already established that even when somebody has normal blood pressure, their risk of developing kidney disease if they're African Americans is significantly higher. And so if we look at the population of people who develop end-stage renal disease every year, between 900 to 1,000 African Americans will start dialysis or start with a preemptive kidney transplant. The corresponding number for non-Hispanic whites is less than 300, such that over a lifetime, an African American that is born and over their lifetime, they have almost an 8% risk of developing kidney failure compared to non-Hispanic whites. The percentage is less than 2%. The question is then why? If you were to look across the world where there are people of recent African ancestry, the numbers in the United States, even though they are large, 35,000 African Americans going on dialysis every year. When you look at the Caribbean, the number is closer to the United States. In Brazil, it is 3 times the number of people compared to the United States who go on dialysis. In Sub-Saharan Africa, it is 500,000 people who develop end-stage kidney disease. If you got end-stage kidney disease in the United States, you will get dialysis or transplantation for sure, unless you choose not to get maintenance therapy. In Sub-Saharan Africa, the number is only 1 to 2%. That means that most of these 500,000 individuals are not individuals who will benefit from any type of renal disease care in terms of end-stage renal disease care. So the significance or the importance of preventing end-stage renal disease is a matter of life and death in Sub-Saharan Africa compared to anywhere else in the world. And Africa is not a small place. It has more than 1 billion people. Most of those people are of recent African ancestry, but most of the rest of the world will fit neatly inside Africa. And it has a large and growing middle-class population. For a variety of reasons that is not the subject of our discussion today, I will not delve into the significance of this continent for the entire humankind. Our work in Sub-Saharan Africa in the context of global health has been supported by the NIH and the Wellcome Trust under an initiative called the Human Heredity and Health in Africa, or H3 Africa for short. This consortium was established in 2010-2011 for the purpose of increasing the number of African scientists who are competitive in clinical translational research, to help establish collaborative research network across the continent, to create an infrastructure for clinical and translational research on the continent, and also to help advance genomic research across the continent. Simply because the need for this consortium of H3 Africa was that if you look at research that was done in Sub-Saharan Africa, they are usually fly-by research, where people go to the continent, collect samples, bring them back to the Western world, and do their research without any benefit to the people on those continents. So far, the NIH had committed $150 billion to about 45 projects with 300 investigators in 38 African countries. Our project is one of those 45 projects. This is a result slide from the African American study of kidney disease and hypertension. The reason for this clinical trial was to see whether effective treatment of hypertension using specific drugs as a secondary objective will lead to a reduction in the risk of kidney failure among African Americans. As I pointed out at the beginning, Dr. Contreras and myself participated in this clinical trial. And the motivation for this clinical trial was the earlier slide that I showed you that was subsequently supported by other data that shows that among hypertensive individuals, the risk of kidney failure was 3 to 4-fold among African Americans. As you can see here, despite adequate blood pressure treatment, close to 40% over 5 years develop an adverse outcome, which could be doubling of serum creatinine, end-stage renal disease, death, decline in GFR. At the end of 10 years, about 60% of participants in those clinical trials had developed a worse outcome despite an excellent blood pressure control that was achieved in the study and post-study follow-up. In fact, until the SPRINT clinical trial, the average blood pressure of 127/74 that was achieved in the ASK study was the best blood pressure goal achieved in any clinical trial ever performed anywhere in the world. Despite that, 60% of individuals in those trials develop an adverse pre-specified endpoint, suggesting clearly that hypertension alone was not the problem. If there had not been adequate blood pressure treatment in this population, the numbers of people who reach an endpoint would not have been 60%, it would have been close to 90%. So blood pressure treatment is very effective in reducing the risk of progression to end-stage renal disease. It is just that it is not enough for a significant fraction of patients. a few years after the results that I just showed you were published, apolipoprotein L1 were identified as a potential risk factor for kidney disease. Apolipoprotein L1 genes are genes that are on chromosome 22, and what those genes do is that they encode a protein that helps to kill the trypanosome parasite in one of the species of trypanosome. The trypanosome parasites evolved to trypanosome rhodesiense, and the rhodesiense parasite was able to prevent the killing of the parasite by apolipoprotein L1. So to be able to combat this particular trypanosome, it believed that there was an evolutionary sweep that selectively select for a variant of apolipoprotein L1 that restored the ability of apolipoprotein protein to kill trypanosome parasite and prevent that infection that is commonly called African sleeping sickness, because it leads to a chronic neurodegenerative disorder that is similar or present like a coma that lasts for months, if not years, hence the name African sleeping sickness. 10 years ago, investigators in Boston at the NIH and at Wake Forest identify APOL1 as not only a trypanosome lysine factor, but also a factor that could lead to the presence of kidney disease, to the risk of kidney disease in African Americans. Several studies had since then showed that if you have two apolipoprotein variants, G1 and G2, you had an odd ratio of 7 for developing kidney disease due to hypertension, 10 for FSGS, 5 for non-diabetic kidney disease, an odds ratio of 29 for HIV-associated nephropathy, an odds ratio of 2.5 for garden variety chronic kidney disease in the atherosclerosis risk in the community study, and an odds ratio of 1.88 for progression of your chronic kidney disease. These variants, because they evolve in Africa, are not present in individuals who do not have recent African ancestry, or at least they are not detectable to any appreciable extent. So it is these type of findings that led us to Sub-Saharan Africa in the context of the H3 African Consortium to further try to understand APOL1 associated kidney disease. Our goal was to assemble a cohort of 8,000 individuals to conduct a prospective study, to train research personnel, to establish genomic laboratories, a repository to help investigators here in the United States and in Sub-Saharan Africa, and to conduct translational research work in both adult and pediatric glomerular disease. We assembled 22 academic medical centers in 7 Sub-Saharan African countries. And since we don't have expertise for everything that we wanted to do, we also assembled 10 North American institutions to work closely with us. Some of these institutions, of course, joined the program as I moved from Michigan to Arizona to Kansas. So we have, over the last decade or so, we have embarked and have been conducting various studies. There was a study, a case control study of 4,000 cases and controls with CKD, in which we did GWAS on a specially designed African custom array with 2.5 million SNPs on an Illumina platform. We are conducting a prospective cohort study with 1,000 individuals undergoing diagnostic kidney biopsy at the onset of their glomerular disease. We are conducting a study of HIV-associated nephropathy. And I'm going to spend some time to talk about only this case control study. Tomorrow, when I speak to the nephrology division, I will spend more time on the case control, on the cohort study. with the biopsy series. It took a couple of initial years and continues to be a source of headaches and sleepless nights to establish an infrastructure to conduct a state-of-the-art clinical research on the Sub-Saharan African continent. I show this to reflect the complexity of the activities and the challenges that one faces in this type of undertaking, but it is doable. It's even more complicated if you were to do type of research that requires kidney biopsy, because then you have to deal with preservatives of different kinds and transportation logistics, as well as analysis of those biopsy tissues. In our case control study, before COVID-19, we were able to get DNA samples to Sherry Winkler's lab at the NCI on about 6,500 people. The DNA samples on the remaining 1,500 individuals were stocked in Accra, Ghana, because of the ban on travels that was imposed at the start of COVID-19. Of those individuals, we were able to get complete clinical data on about 5,800. 3 individuals did not have their sex data. We couldn't find those individuals, so we excluded them. And about 89 people did not give urine for urine albumin creatinine ratio at the time of enrollment into the study, probably because they were anuric and on dialysis. And so we ended up with genotyping for APOL1 on 5,700 individuals, consisting of 2,300 controls and 3,500 cases, CKD cases. These are the baseline characteristics of those populations. And what is important to note here is that, in fact, there is a, among cases and among controls, blood pressure was not terribly high. Admittedly, some of these people are on different type of treatments, but it is notable that the degree of proteinuria or albuminuria was significant in both males and females, and about 1/3 of those individuals with kidney disease, and HIV was present in almost 800 individuals of those 6,000 individuals. Please note that the anemia, even though it's a classic, we will not be surprised with anemia in individuals who have CKD, but the level of anemia among individuals who have CKD was identical to those individuals who did not have CKD, with a GFR of about 800. And about 200 individuals also have sickle cell trait. So what did we find in that case control study? We were able to elicit for the first time, not previously reported in any large series or in any systematic study, that the age of onset of end-stage renal disease among Africans living in Africa was 43 years, 15 years lower than African Americans in the United States, and more than 20 years lower than non-Hispanic white in the United States. So not only do people not have access to dialysis, the age of onset of ASRD is right at the prime of life when people have their highest earning potential. If you were to look at the distribution of the APOL1 G1 G2 variants, I want to note that individuals who have 2 APOL1 risk alleles are the ones that are definitively confirmed to be at increased risk of kidney failure. We do not know whether individuals with only 1 risk allele have increased risk, although they may do, but that data is not conclusive yet. The fractions of Africans living in Africa who have 2 APOL1 risk was 28%. It ranges from 26% to 28%, depending on which of these subgroups you look at. I just want to note that the African Americans who have 2 APOL1 G1, G2 variants is only 13%. And so those individuals who, by the virtue of having these two risk alleles, and therefore at increased risk of kidney disease, are 13% of African Americans and 28% of Africans living in Sub-Saharan Africa. If you were to break down the presence of these two risk alleles for different categories of CKD, what one finds is that it is only individuals who have no albuminuria that had a risk ratio that is as high as anything close to what was found in the United States. That is an odds ratio of 2.44 in the ARIC study. Otherwise, most of the odds ratio or the effect size in this population are significantly lower than what you will see among African Americans, suggesting that it is not that APOL1 is benign in this population, but there are other factors that are also driving and maybe overwhelming the APOL1 effect in Africans who live in Sub-Saharan Africa, in contrast to Africans in the United States. As I said, the risk for APOL1 ranges from 1.88 all the way to 29 in the United States. And if I go back to the slides, the highest odds ratio is about 2 or slightly over 2, 2.21 in individuals who had albuminuria. University of Miami, in the division of nephrology and hypertension, is participating in this nephrotic syndrome study. And I want to use nephrotic syndrome study to network to illustrate an important point about global health research. There are 26 centers in Neptune. Neptune has been going on now for about 13, 14 years, and it has received close to $20 million in funding. In the Neptune, 115 individuals of Black race, African Americans, have been enrolled over the 14-year period. In the H3 Africa Consortium, we have received somewhere between $6 and $7 million over the last decade. We have been assembling a biopsy cohort for 3.5, almost 4 years. We have enrolled about 750 individuals into the biopsy cohort. 722 have undergone kidney biopsy. We have results on those individuals. So in a very short period of time, 1/3 the amount of time, and with 1/3 funding, we were able to assemble a biopsy series. I'm not dinging Neptune because I'm part of Neptune, but I'm pointing out to you the efficiency of conducting clinical translational research in the setting of global health, as has been pointed out in other settings. In our biopsy series of 772 individuals in Sub-Saharan Africa compared to 440 in the Neptune, what you will see here is a major difference in the presence of FSGS if you look at the perihilar type, Neptune has a large fraction, but we hardly see perihilar disease for FSGS among Africans living in Sub-Saharan Africa. If you look at collapsing FSGS, it is significantly higher in Sub-Saharan Africa compared to the Neptune series. And if you look at individuals who had cellular type FSGS, it is low in both populations, almost non-existent. These type of findings are important because they help to illuminate significant differences in disease that are that are associated with race. Whether they are associated with race because race is a biologic or a social construct is not clear. The work that we are doing on chronic kidney disease in Sub-Saharan Africa is covering the range of clinical translational work, starting with basic genetic and genomics works all the way to clinical outcomes research and hopefully clinical trials. We are working currently to establish a polycystic kidney disease, autosomal dominant polycystic kidney disease cohort in Sub-Saharan Africa, because there is none anywhere in the world. Okay, and we don't know anything about polycystic kidney disease in Sub-Saharan Africa. We are working with people from different places across the United States. So my plea to you, and one of the purposes of my giving this presentation, is to ask that if you have expertise and interest, the H3 Africa Kidney Disease Consortium welcomes you to contribute your expertise and knowledge to the work that we are doing on this on Sub-Saharan continent, because we will never have enough expertise to be able to unravel the scourge of kidney disease in people of African ancestry and understand and mitigate that excess burden that we see in African Americans. I want to close by noting that clinical and translational research work is hard, but it is feasible in low resource setting. For much less money, you can achieve significantly greater efficiency simply because of population size. It's an important diplomatic tool for the United States. In fact, it's a national security concern for the United States. That's why the Department of Defense spends a lot of money on global health research. It may be the only practical option. For example, if you wanted to study a condition like CKD of unknown etiology, you will be hard-pressed to find enough cases, if any, in the United States. And by sheer population, we are only 4% of the world population in the United States. Extending our field of research to the global arena allows us to have access to the majority of those 7 million people who now occupies the world. I think engagement in global health research should be an important mission for an academic medical center like yours with a lot of talent and expertise, and foreign component of domestic awards is a major source of funding that you should consider when you are thinking of global health research, with appropriate justification why you need to do the research outside the country. I hope I have reminded you that compared to African Americans, West Africans in Africa have a much higher prevalence of risk alleles, and that the age of onset is much lower for end-stage renal disease in Sub-Saharan Africa. The odds ratio is significantly lower for APOL1 associated disease. NIDDK appointed an observational study monitoring board for us. We would not have been able to do the work that we are doing without the input of these exceptional individuals who constantly give us input, criticize our effort, and provide guidance to us. And here are some of my colleagues on the continent, as well as some of my colleagues in the United States at one of our annual meetings. Thank you very much for this opportunity and the privilege of participating in the Cuneo Richardson Endowed Medical Grant Round. I will be glad to take questions to clarify my comments.
Thank you, Dr. Ojo, for a very excellent and inspiring grand rounds that was able to combine both kidney disease and basic understanding and knowledge about how to perform global health research. And indeed, as our world gets smaller in terms of our ability to communicate based on technology, we still haven't quite adapted to the ability to overcome cultural differences that are so much apart, and you alluded to, in being able to do research in different cultures and in different environments. Indeed, we see this in our own community in Miami as to how to engage community-based researchers and with the community. So what advice do you have in terms of an investigator who obviously may have a particular problem that would lend itself to specifically Africa or sub-Saharan Africa in order to overcome the cultural differences that are so important in being able to do research? Do you have local groups that help you with that, and how does that work?
Thank you very much, Dr. Wells, for that question. It's the question that you raise is a critical success factor, being able to have the appropriate level of cultural competency, as well as being able to engage people on the ground as true partners in the effort that is being undertaken. So we have about 120 investigators in those 7 sub-Saharan African countries who are permanently there. And we are able to engage with them in discussions and put them at the forefront of deciding the research questions, as well as contributing to all aspects of protocol development, as well as manuscript development. We have not written a manuscript that was not, that the first author has not been one of our African investigators. And we do not go to any society without making sure that we have the support of the local government, maybe be it at the level of the Ministry of Health or the equivalent of the State Department or other important governmental entities, because I believe that those governmental entities are equally important in being able to be able to do good work on the ground.
Amazing coordination. Thank you so much. Please, let's open the questions up to anybody on the Zoom call. If you have a question, please unmute yourself, or you can put it in the chat.
Dr. Ojo.
Yes.
This is Gabriel Contreras. Well, thank you very much for your mention in your great talk. My question is something that come to my mind, whether the APOL1 risk allele become more determinant at a later age in African American patients. There's a 15% difference in the age population compared to the cohort on Africa. And I wonder if you have done a subgroup analysis stratifying by different age era of the population and see if the APOL1 odds ratios, increase the older the population gets compared to control.
We have not done that analysis, or at least if we have done it, I don't have that file, but that's an important question. We will go and look at the prevalence or the allele frequency by age group. That is important. And in our cohort study, we will also be able to capture whether APOL1 risk variance is more of a disease-causing variant versus, or whether it is also a progression variant.
Yeah, my feeling is that maybe at a younger age of person of African ancestry, maybe other risk factors are more important than the genetic component of the APOL1 nephropathy variants. But at a later age, maybe become more significant, and wonder if something like that is happening. Would be interesting, I think, to know if in African patients in the African cohort at the age of 60, 65, the odds ratio increases.
We will definitely do that analysis that you have suggested, Dr. Contreras, and I'll make sure that you have the result.
Dr. J, do you want to say something?
Yes, wonderful talk, Dr. Aju, Professor Dean Aju. I have a question about the role of HIV and hepatitis C on the renal disease, especially with the different subtype of HIV, subtype C in Africa.
From the case control study that I showed some of the data, we have about 500 cases who are HIV and maybe close to 400 HIV cases among the controls. And we don't have the opportunity to look at progression in the context of HIV and hepatitis C in this particular case control group. We do have a prospective cohort study of 4,000 individuals that I will talk about tomorrow. And we don't have enough follow-up to be able to see the effect of hepatitis C. But once we get another year of follow-up in that prospective cohort study, we'll be able to look at the interactive effect of hepatitis C and maybe the interactive effect of hepatitis C and APOL1 together. Unfortunately, the cohort study are individuals who are HIV negative. And so we won't be able to speak to the effect of HIV on progression or whether it has an interaction with APOL1.
Thank you.
For our last question, Dr. Fornoni.
I didn't raise a hand for questions, Roy. So.
Oh, I thought you said you had a question. All right. Then in that case, I would like to thank Dr. Ojo Dean Ojo for a great grand rounds. I also want to thank the families that enabled this grand rounds to take place. And of course, Dr. Fornoni for inviting our speaker. So thank one and all. Please be safe and we'll see you next week. Thank you.
Thank you.
Enjoy your stay in Miami.
I will.
We'll have to secure that he can come back in person when this is
Definitely.
possible.
A rain check will be given.
Thank you.